Good morning and welcome to today's Inspire Respiratory Critical Care Ask the Expert Anything panel discussion. Today we are going to, if you recall, the last two sessions that we had were on non-invasive ventilation and high-flow nasal cannula. And we felt like that we needed to have one more session and sort of talk about both those things concomitantly. And sort of talk through some of the reasons maybe why you wouldn't use one over the other. So we'll start out like we usually do, just by introducing ourselves. My name is Keith Lamb. I'm a respiratory therapist at the University of Virginia and work on the trauma, surgical, and neurosurgical service. And we'll go to Tom.
My name is Thomas Prano. I'm a respiratory therapist, educator, and consultant in Ontario, Canada.
Dr. Scott.
Hey, everybody. My name is Brady Scott. I'm a respiratory therapist and associate professor and a program director at Rush University in Chicago.
Hollywood.
John Encrott, flight respiratory therapist, Advent Health, Orlando.
Andy.
Good morning. Andy Klein. I'm a respiratory therapist, educator at Rush University Medical Center in Chicago.
Eric.
Good morning. My name is Eric Kiner, respiratory therapy clinical specialist at MedStar Washington Hospital Center in DC.
Carson.
Karsten Roberts. I'm an assistant teaching professor and director of clinical education at Thomas Jefferson University in Philadelphia.
And Julie.
Good morning, everyone. I'm Julie Jackson. I am a clinical affairs specialist with Fisher and Paykel Healthcare.
And that's the team today. Thank you all for joining us. Tom, do you want to bring up the slide?
Bam.
Beautiful. So we'll just go ahead and go around the room. We'll start with our first talking point here, and everybody can sort of just chime in. If you're listening to this live broadcast, then you can ask questions in the chat box, and we'll try to address them. So first talking point is, how does one decide on which of the two therapies to initiate first? Who wants to take that one?
I mean, I can say that we covered this in our last two webinars, so everyone should go and watch them. But let's summarize now. Essentially, looking with the strongest recommendation, I think we should be considering. So right now, the strongest recommendation for non-invasive ventilation would be in hypercarbic respiratory failure. So that would be clearly if the patient is hypercarbic and this is an issue of CO2 clearance, probably the non-invasive ventilation would be the one to initiate first. And if the issue is purely an acute hypoxemic respiratory failure issue, then we should likely initiate high-flow nasal cannula first. Those would be my recommendations to start.
I think to piggyback on what Tom said, it differentiates between type 1 and type 2 respiratory failure. And hypercarbia, we know that this works with patients with COPD exacerbations and cardiogenic pulmonary edema. So figure out which one you have. If you're dealing with straight hypoxia, or hypoxemia, then maybe heated high flow would be your first go-to, as opposed to a BiPAP or bilevel.
And we should acknowledge that there are studies of using high-flow nasal cannula that it can reduce CO2. But in those studies, many of the patients end up crossing over to NIV. So if you're in a situation like an emergency department and your patient is hypercarbic, then we should, likely start the therapy that you're known they're more likely to transition to if they were to fail high flow. However, patient tolerance is extremely important. So if your patient's not tolerating it, then obviously this is also a role for high flow to try and reduce the need for escalation of care. But I think probably the hypercarbia would be the trigger for an NIV initially.
Hey, Hollywood.
Do you think we should kind of, I don't know, maybe make the clarification hypercarbia with acidosis? because if it's fully compensated or
Yep.
at least pretty close, there's that kind of gray area, the 2017 guidelines.
Yeah, that's actually a great point, Eric, because they actually recommend against the use of preventing respiratory acidosis. So if your patient has a high CO2, yes, it's with associated acidosis.
Yeah.
We should clarify. That's a very good point.
Yeah.
Hollywood, what constraints in terms of pre-hospital choices do you have? In other words, is one more readily available than the other?
Yeah, some of the county EMS and city EMS systems use, I forget what it's called, like an easy flow or easy something, where they just set a spring valve to the pressure that they want. And those masks are limited to, I think, 7.5 of CPAP. So there are limitations there that pre-hospital folks will run into. From an interfacility transport perspective, what I do, maybe what Joe Hilton does, we have our, equipment that kind of performs with whatever we want to do, whether it's high flow or non-invasive positive pressure. But there are pre-hospital constraints from the county and EMS systems. And I think we covered in one of our last talks too, that Julie had brought up, that there are now devices, I think one of hers, that goes up to 70 liters per minute. That's just not something that we will do in our aircraft. And as Joe Hilton had pointed out, there are constraints to other systems or EMS systems taking patients on high flow because of the oxygen demand issue. So yes, there are some constraints to pre-hospital folks when they use this. There's certainly not any heated high flow devices in the county EMS system, but we can do that with interfacility transports.
Do you use a transport ventilator platform that can do both high flow and non-invasive ventilation, like a system that has a turbine that doesn't chew up oxygen that fast?
Yeah, we use the T1s in our program, and obviously I think Joe's program does as well. So we have a platform that performs anything that we want to do, whether we need to cross over, as Tom had pointed out, into from heated high flow to NIV, or even from NIV into mechanical ventilation. So we can certainly do that.
I just want to add one thing. There are more and more EMS crews out there, to John's point, that are like being outfitted with these different devices so that they can provide the therapy from a high flow perspective and non-invasive. I know, like here in the Des Moines metro area and a lot of our county hospitals, one of the hospital systems decided to invest money in outfitting all of the county hospitals and all the county EMS with the opportunity of having high flow. So I think there are more and more that are looking at it, but there are limitations, as John pointed out.
And I think, again, a lot of us working in critical care and in the ICUs don't really know what happens out in this EMS system. And, cost constraints are huge when it comes to stuff like this. So I would love to see, as Julie had said, I would love to see other EMS programs outfitted with these devices that they can perform this, because I think pre-hospital care translates into what happens in the ICU when the patient gets there. So it's important that we educate our pre-hospital personnel in these devices and in these interactions or adjuncts that we use, so they can treat the patient accordingly, and we can get them as a lateral move as opposed to somebody who's maybe in worse condition.
Yeah, I think it's important. An important consideration is when you're doing inter-hospital transfers, that you continue the therapy that the patient might have been receiving before they left their current facility. So even just given that point, that I think it's important to have the resources and the knowledge base by the transport team. Carson or Brady, do you have any, or Andy, do you have any educational considerations that any specific way that you teach these concepts on how to choose devices?
No, I mean, from a so I did. It's funny you asked this question the way that you did, because I literally put my academic hat on before Tom started answering, because the question was, how does one decide which of the two therapies to initiate? So I think that, speaking that, I know that Andy and I work together, I think that we would probably teach our students, what does the evidence say first? So, we try to drive a lot of evidence-based practices in our curriculum to make sure that they are aware of these guidelines and things like that. So, and we also talk about some of the weaknesses or some of the limitations that exist in the literature, and try to get them to critically think. But then, also talking about, all right, so you take the literature and we say, okay, well, it seems like hypoxemic respiratory failure is good for this group, and hypercapnic respiratory failure may be better for NIV, at least what we know, maybe not always or whatever. But also moving down one other level to, okay, so now let's look at the individual situation. Right? Is the patient cooperative? Are they not cooperative? So sure, I want to use it, but they won't use it at all. So despite what the evidence says, the individual won't cooperate. So I think we kind of track them down that same mindset to think, here's the evidence, here's the individual, let's look at this. And then if they can't go, then what's the alternative? So I think that's a general way we would handle that in the classroom. You want to add to that, Andy? Or Carson?
Yeah, I think you made a lot of sense there, Brady. And I think the most important thing you really teach them is how to assess and critically think through the individual patient scenario. And I think some programs do a better job of that than others. I know we all went through different programs. We can all probably speak to our individual experiences with that, but availability of resources. I know some programs may not have all of the different high flow cannula modalities and different NIV modalities that you can choose from, so they may not come out as prepared from those places as we might like. But I think regardless of what your platform is, the most important thing is
I think
I
Andy
lost
just
Andy.
froze.
Dang,
go from
Andy.
there.
He said the most important thing
Oh,
is,
there
and
we
then
go.
he just stopped. Andy, as soon as you got to the major point, you said the most important thing is, and then you dropped out.
Yeah, start back at that point.
Sorry, I'm at work. I should have a good connection. So no, I was just saying that the most important thing is, regardless of your platform, is teaching your students, I think, and your new therapists how to think through those scenarios, and assess the individual patient, the individual limitations and indications and contraindications, and then make the best choice you can based on that.
So to that point, I teach the same as Brady and Andy do, evidence based. So I too put my academic hat on and pulled up my last slide presentation that I gave to my students on this very topic, and the exact same. Even before our previous session here with you all. I had already included both of the same guidelines in our curriculum this semester. And so when it came down to, I taught it right at the end of the semester, where they have equipment and techniques, where they're learning what high flow and non-invasive are for the very first time. But then I came back to it at the end, and we'll talk about this in a little while, at the end of this semester of their introduction to mechanical ventilation, for the decision-making process for what do you do when you extubate somebody from invasive mechanical ventilation. So we actually cover it a couple different times in two different classes. And the way that I run my final exams, my students have to assess a patient. They get the patient from intubation, and they have to work their way through assessing the patient as they go through, and they're getting checked off on their competencies as they work through the simulation. And then at the end, when they extubate the patient, they have to decide, based on what they saw with this invasively ventilated patient, what they're going to extubate, what device they're going to extubate to, and how they're going to set up that device once that patient is extubated. So very, very similar, evidence-based and assessment skills. I tell my students, assess the patient, assess. You can never assess the patient too much.
Right. I would like to add this that, and so this is certainly an opinion of mine, so I'll just close that. But I think that this is a high flow nasal cannula, especially and non-invasive ventilation, are two perfect examples of why students should be introduced and taught to consume research from the beginning. I mean, I've been a respiratory therapist long enough, so I've been a respiratory therapist for almost 24 years. When high flow nasal cannula wasn't even an option at the bedside, it wasn't even a thing. We didn't even own them, right? So we had to do like the dual setups of the air, the high flow aerosol devices and things like that when we needed a higher FL2 on folks. And and then watching, high flow become like this. I always call it, back in those days, I felt like it was a solution looking for a problem. We just weren't sure what to do with it yet. So, and then we gradually got a little more comfortable with its use, and then gradually got a little more comfortable with its use. And then, we've all, because of that, I mean, everybody in this call, we've had to be kind of nimble with what our practices have, where normally we would have just put everybody on non-invasive ventilation. And even EMS would have put those patients on CPAP, right, as they're coming in for cardiogenic pulmonary edema. And now we're looking at other ways. And so as the evidence is evolving, we're evolving with it. So I think it's incumbent. I think we must teach the students to be nimble in similar way, like be willing to change as the data and the technology evolves. And I think that it's not just students. I think that's why really every RT should try to become more and more of a consumer of the literature, because it does evolve. I think, Keith, was it in 2017 that you and I debated? I think it was right. That was the topic we debated, was the use of high flow nasal cannula versus NIV for acute respiratory failure. Right. So in 2017, I was in defense of non-invasive, and it was an easy debate because my data was better than yours. But then you fast forward to what is it, 2022, Carson, when you did that same debate again, all of a sudden the tables turn, because the literature starts to move in a different way, which is a perfect example of why I think that we need to make sure our students are really tuned in to the literature and how there's an evolution over time.
Yeah, I remember that pro-con very well. I took kind of a shellacking.
As someone who was in the audience for that debate, gentlemen, it was incredibly entertaining and my favorite talk of that conference. Just throwing that out there.
Good.
Did anyone see me debate Dean Hess on the use of high flow for hypercarbic respiratory failure? Yeah, that was fun.
Is that when you called him a boomer?
I might have. I don't know.
I think you called him a boomer on that one. I think that was good.
We had a lot of fun going back and forth. But yeah, hypercarbic failure, classically non-invasive ventilation is clearly the strategy, and I had to argue using high flow against Dean Hess. So that was I mean, I emailed Dean before that, and I said, "Hey, Dean, I hope you're ready for a 20-minute stand-up comedy show," because that's about all I had. I just added one of the comments up here. I'm happy to comment on the HACOR score. I've mentioned it numerous times in talks over the years. So the question is, can you elaborate on the HACOR score, and from a pre-hospital standpoint, are there any ways to evaluate someone's progress on NIV or high flow nasal cannula? If you don't have point of care testing, can you use end-tidal CO2 during NIV application? So I'll start quickly with the HACOR, and then maybe, John, this might be a good comment for you. The HACOR score is heart rate, acidosis, CO2 oxygenation, and respiratory rate. It's a paper that was published by Dwan and colleagues. 2017 was the first one that came out. They've recently published an updated one of that, 2022, which I will paste in the comments right now. That's a link to the article. You can copy and paste that. And basically, it's utilizing these readily available values and giving you the option to put them into a little calculator. Again, they don't have a calculator. I should probably add this to my calculator site because I've talked about it for so long and it would be an easy thing to do. But essentially, you rate your patients, and then depending on the scale, it predicts the probability of failing non-invasive ventilation. And the nice thing is that it's something that is quite accurate at 1 hour of therapy. And I've heard many people over the years say this. I believe I've heard Dean say this a number of times in talks, but non-invasive ventilation success is determined within hours, not days. So generally, patients that are going to fail non-invasive therapy, you should know within 1 to 4 hours that they're probably going to fail. And at that point, you're just sort of prolonging the inevitable. If you are aware. So this is just one tool. This HACOR scores is one tool to evaluate that probability of failure. And of course, the higher it is, the more likely you're just moving chairs around the Titanic if you're not intubating the patient. So, John, I think you should probably be a good comment for that pre-hospital point of care.
Yeah, without point of care testing, it's a little difficult to determine acidosis. So you could certainly have an elevated CO2 on an end tidal monitor, but it doesn't, like we had said before, it doesn't necessarily translate into acidemia. So I think it'd be a little bit difficult. We don't carry point of care testing on our aircraft. Because we are strictly interfacility, whatever labs we need, we can get before we leave the facility. Generally, I don't make a whole lot of ventilator changes in the air. I'll do that on the ground. Can you use end tidal CO2 during NIV application? I don't know how accurate that is. Maybe my colleagues here can elaborate on that. We don't care. I don't use end tidal CO2 on my non-invasive patients. I think Tom covered HACOR really well. So I really don't have anything to add to that. I think it's difficult to use that scoring scale in a pre-hospital setting without point of care testing. I think it'd be a little difficult.
I agree. Yeah, the HACOR score would be challenging because it does require knowledge of the level of CO2. Well, actually, I believe it's pH, if I'm not mistaken.
Yeah.
That one of the scores is for pH, which is the acidosis part.
Yeah.
Yeah, I think.
And actually, the C might not. Let me just look at this. The C might not actually be. It's consciousness. Sorry, C is not carbon dioxide. That was my mistake. It's heart rate, acidosis, consciousness, oxygenation, and respiratory rate. So my correction on the C.
You know what? I think this goes back to what Karsten said. I mean, assess, assess, assess. And when I teach my UF students, it's the same way. You cannot assess enough. So if you don't have these things, if you don't have all these great numbers from a POC or whatever testing device that you use, assess your patient. How do they look clinically? You know, if you have somebody who's got a SAT who's 90 and they're on crazy settings and they're breathing 30 times a minute, I think you kind of know that they're probably not going to do so well on NIV. But assess, assess, assess.
I think what Dakota might have been asking was whether or not you can use capnography as a surrogate for hypercarbia to, you know, and supposed acidemia. And I don't think that you could.
I don't think so either. I was going to say with an abundance of caution, but actually, no, I would not count on that surrogate as a good mechanism.
Again, your assessment skills are probably the most important thing that come in play in this particular scenario. And I wanted to just go back real quick and say if I understand the educators and their points that they were trying to get across is that science first, art sort of comes in play after you have a really strong understanding of the data and the science, and then being able to take that and apply it to the patient that's in front of you via assessments. And
you know, I mean, I guess at the end of the day, I don't know that that there's a chronology there, to be honest with you. I think that what we try our best to have the students aware of what the evidence would help with decision making, right? But you know as well as I do, a lot of these things are happening very quickly. But you know, I just think I think as educators, we need to keep them focused on how the literature drives our practices. But I don't think it eliminates experience in the art. I just think that they supplement each other. I think we can't always say, well, in my opinion, you know, that's really not a great way to practice medicine. It's constantly, well, in my opinion, right? Because that's one person's opinion that can't be studied, right? That can't be evaluated if it's right or wrong. So I think that I think that in educating a young mind or a newer respiratory therapist, even if they're out of school, we got to attach their assessment skills with the literature and have them put it all together so they can critically think in the situation they're in. And I just want to, now that I'm off mute, I just want to say that I think that this whole assessment piece is, I mean, you can't say it enough, right? I mean, you put a patient on, they're diaphoretic, they're tachycardic, they're tachypnic, there's, and you put them on non-invasive ventilation or whatever, and then some of those physiologic numbers start to normalize. You don't necessarily need a blood gas to say that this is getting better. You can see that this is improving. Blood gases are important. I'm not poo-pooing them, but you can sometimes just talk to the patient. They tell you they feel better. I kind of jokingly say, when a patient begins to complain about other things that are going on in the room other than breathing, I feel like I've won. I'm like, when the room is too hot, or the lights are too bright,
Or I'm hungry.
or I'm hungry, or can you get a pillow for my whatever? I'm like, yes, because a few minutes ago there was no complaints over that, because it was, I can't breathe. So I'm like, there's so many little things that clinicians can do to try to see that we're moving in the right direction. Again, I'm not taking away from the HACOR scores and blood gases, but it's like the beauty of healthcare, right? It's the art. We put it all together, and we make these decisions. And I think that's a little bit hard to train, but that comes with experience. But it's good to talk to students about.
Yeah, when you mentioned using the dual devices, man, I started having these flashbacks. I'm sure we just used to intubate those people a lot sooner, right? We just didn't have any sort of intervention. So, yeah.
I think this ties nicely into Troy's comment here, where, similar to what you just said, Keith, like, we didn't have the ability to deliver high concentrations of oxygen with high flow rates until somewhat recently. Again, the Florali trial was published 2015, which might sound like a long time ago to some people, but you'll notice many people called any research in the last 10 years recent, because it usually takes almost 10 years to actually get it into clinical practice when it's proven to be helpful. But, Troy makes this comment that this ability to deliver this high concentration of oxygen and use it for days on end, due to the plethora of interfaces available, he's just saying that may have been abused a little bit during COVID, where we sort of, and I know I saw this particularly, where it's the typical criteria we used to use for intubating people. Sometimes we were forgetting the typical criteria used to intubate people. So people that were on high flow nasal oxygen for days on end were meeting criteria for failing, long before we end up intubating them. And I'm sure we all saw patients that did well, like we thought they get intubated, and ended up doing well. But I've seen just as many patients, be on this therapy for a very long time and then fail, but they were essentially failing for days. So Troy's comment was that this can be where the scoring tools may be helpful, that you can at least advocate and say, according to these tools, which are validated tests, even if, something like the ROX index, even if you don't go specifically by the threshold that they use in the paper, if the number is really, really, really bad, and it's been that way for days, or you see the trend going in the wrong direction with these scales, you can at least advocate and say, this patient's met, like, they have a high probability of failing. It's even higher today. And, are we waiting for something magical to happen, or should we probably make the decision to intubate these patients? But this is, it's a clinical decision. I never recommend going by one tool or one scoring tool, or one parameter, but when you have a combination of these parameters, and how your patient looks, I think, we should probably get back into the practice of recognizing failure and calling it for what it is, instead of just trying to wait and see all the time.
They're tools in a toolbox, right?
Yeah.
I mean, you don't necessarily use them every single time with every single patient, but you have them available to you. And, just like what Brady was saying, we don't necessarily go in a specific order, like evidence and then art and then application. It's all together on the same plate. I'm gonna stick with my dinner plate analogy that my student gave me this semester. He said, you always go high. You always give us the whole meal, and it feels like a lot. But then you go back and you start, looking at the items and you start describing each individual thing on the plate, and it makes a whole lot more sense. So like the whole thing is still there. It's just, there's still the art, there's still the science, and then there's the application. And it doesn't change anything. I mean, it still takes it back to like, we have to assess which is the best tool to use in this situation. Is it the rock score? Is it Paycor? Like whatever it is.
Yeah, I think that what I meant was you may teach in a specific chronology, but in practice it's all concomitant, right? You've got all these things in mind when you're in front of the patient, which is when it counts.
So let me bring something up, maybe just kind of for discussion purposes. It kind of plays off with Troy's comment, and then maybe some of how to choose, when to choose, because this is, so the alternating, the 2022 high flow guidelines say, just say use high flow as opposed to conventional oxygen therapy to alternate, right? And so we've taken that idea a lot of the time, and it's thrown out at a prescriber level, probably just say, all right, switching back and forth, that type of thing. Do you, and I'll just tell you from my experience, like, to each his own at that point. Like, it's just like a lot of people will keep on a non-invasive until the patient kind of isn't tolerating it, or something is coming up with their care plan or something, and say, okay, things would be easier if we were on high flow at this time, right? And they make that kind of judgment in that way. Do you guys see, or are you using any criteria to say, all right, 4 hours on, 4 hours off, 6, or whatever have you? Or are you just kind of seeing people making it up as they go along, and it's kind of this kind of carte blanche practice? I mean, because it's stated, but not how or when to choose which one. I don't know, just up for discussion, just because it is a really gray area, kind of, as I see it, because I can't provide them any like really strict guidance in that way.
No, I think it's all voodoo. It's all,
yeah.
We're just we're just making it up as we go, and that's okay. I mean, that's in the absence of strong recommendations, that's our job, is to sort of figure out and customize that plan to the patient. I'll talk about this more when I talk about or when we talk about neurostatus and how that plays into.
Sure.
But in my practice, no, I don't ever. It's the same thing. I say the same thing when people say, okay, well, how long should we put somebody on a trach collar? And how long should we rest them on the ventilator? Should we do that? And if we do it, how long? There's no good, that has to be customized to the patient. I don't have a good answer.
Sounds like what we need are a bunch of respiratory therapists who geek out on this stuff to come up with a multi-centered strategy to run protocols and do research, and then put it all together and answer the questions.
If only we knew such a group.
If only we knew a group of people that would do this. We should start emailing people.
Yeah.
Have a multi-center strategy.
Yeah, that's a great idea.
If anybody knows it, may please put it in the chat.
Troy volunteers. Are there absolute contraindications for either therapy? Again, I know that we've discussed these points to some extent in our first two panel discussions. But yeah, I mean, there are, right? There are some, in my world where we have a lot of patients with Lefort fractures, other facial fractures, maybe the non-invasive mask approach is not the way to go. Anybody else have contraindications for either one?
This is Julie. In my previous practice, and I know we're going to get into this with the next question, but we looked a lot about neurostatus as well. Like, what's their level of consciousness? Can they protect their airway? You know, for both, really, because there's a lot of risk for both. So that was kind of another decision point for us. Not just, you know, we looked at facial fractures too, like you said, but a lot of it was, are they conscious enough to protect that airway? And if they can't, then maybe intubation is the route we need to go.
Yeah, Julie, I think you're right. I think level of consciousness is the big one, and airway protection, certainly for us. You know, people that have these full facial beards and mustaches, it becomes a very difficult seal. You know, you get them, they're kind of sweaty, or they have, you know, if there's a little blood, whatever the case may be, sometimes it's very hard to seal those masks on those face. So that gets to be, I mean, kind of a contraindication because you can't get a good seal and you're not going to get good therapy. Vomiting, pneumothorax, I think a lot of these things that you would associate with positive pressure can be contraindications to non-invasive positive pressure. Maybe not so much the heated high flow. So
I think the big one that tends to, you know, we all know, but we don't always include it on lists is apnea, right? I mean, if they're not breathing at all, we need to take over. But I think, and you guys maybe have seen this, you know, where you have, well, can we just turn the rate up on the non-invasive, you know, and just continue to manage them like that, you know, because it's like, no, I mean, I think that's a terrible idea. I think we should, you know, place a breathing tube for them as well. So I think that's a big one we all need to always keep in mind, because we're always going to have those residents like, you know, they have all these reasons I don't want to intubate them, and just because they're apneic, isn't there a backup rate on the non-invasive? And it's like, yeah, exactly, it's a backup rate. It's not to take control of their breathing. So
I'm going to say something. I want to see if the panel, and I'm perfectly fine if you disagree with what I'm about to say or you think I'm crazy. I just want you to, I respect everybody in this room. I would be willing to bet that if you took the rate function off of non-invasive ventilation, I wouldn't even know it.
Technically, you shouldn't. I think this is a problem with setting up NIV, as some people feel that, oh, my patient needs to breathe fast, so I'm going to set a fast rate. But the rate is supposed to be in the if by any chance, it's almost like an apnea backup, essentially. It's if they stop breathing, they have this rate that sort of continues on. But the closer you get that rate to the patient's intrinsic rate, the more asynchrony you're going to have, because it's not like SIMV. Like, this rate only kicks in if there's a long enough period of exhalation before the timing would indicate the breath should be given. So essentially, the rate doesn't exist as long as they're breathing above the rate that you set. So it should be nowhere near that. But I think this is I've seen many patients on BiPAP with a rate set at 20, and I'm like, what if the patient gets down to around, they're just going to become desynchronous and uncomfortable. So really, that rate should be treated as a backup rate. So yeah, well, I would agree. If it was gone, I would probably clarify your statement. If the rate was taken off the machine, there should be no difference in how the patient is managed on NIV.
Well, yeah, that's exactly what I'm saying. I guess my point is I don't use it to manage. If hypercarbia or hypercapnia is worsening and the patient's work of breathing is getting worse and those type of things, at least in the acute setting, all right, that's my background, is in the acute care setting. So I don't have a background in sleep medicine. I don't have a background even in post acute that. So, but I don't know of a single time in my career that I have actually increased one's respiratory rate as a strategy to maintain non-invasive ventilation on somebody who otherwise could be intubated.
Not only do I completely agree with what you said and don't think you're crazy, I honestly think that the patient would be better off if that feature was taken off the machine, right? Because then you wouldn't have people that would rely on this backup rate or increase the rate or decrease the rate based on the status of the patient. They would actually implement the appropriate intervention.
Yeah. I've had, it's kind of one of those, I can know somebody's probably off the call here saying, I don't agree or whatever, but, sometimes I have these conversations with physicians and I'm like, I can tell you at the point in time that I feel like the patient's rate needs to be increased, and we're getting low and the backup rate's there and all these things. I said, instead of doing that, I would come and find you with the laryngoscope in one hand and the endotracheal tube in the other hand and say, it's time, we have to move forward on a patient who can be intubated. So, and we talk about that a lot in as a strategy of another one of those ways of knowing it's time to move on and escalate care.
So we would agree that
sometimes we got to avoid TRIPAP. As much as I
Right.
if you've heard of TRIPAP, it's TRYPAP. Let's just TRIPAP. So sometimes I think that in some clinical situation, intubation is the safest thing to do for patients. And we all know that comes with risk, but we also have to realize it's the right thing to do sometimes.
I like the word bradyapnea.
Yeah.
Right.
One time I was saying the word bradypnea, and somebody corrected me and said, "Don't you mean Brady Pania?" And I said, "No, I don't mean that. Brady Pania."
All right, let's get to the next question. We're doing good on time so far. We got 3 more questions on our list.
Yeah, we have some questions. You want to address those first? Or
no. Oh, sorry. Yeah, those just popped up when I was on the other screen. Let's do that. Okay, here we go. What's your algorithm for improving desynchrony on your NIV patients? As we just said, make sure your respiratory rate is not high at all. Adjusting IPAP or EPAP. When do you switch to medication assistance for compliance? Is there an order you assess your settings and recommendations on medications?
Well, for us, the decision to try to assist asynchrony with pharmacology would be based on what the etiology of what the problem is. If it's pain or if we oftentimes now will use dexmedetomidine for non-intubated patients. It's that might be on NIV, low dose opioids for pain and dyspnea. But again, that's just sort of based on, we have patients that just have so many comorbidities and co-issues that it's hard to make a standard approach to this in my mind.
I think if you're going to do that, I think that assessment becomes very important if you're going to administer some pain medication, fentanyl or the like, or if you're going to administer a light dose of Ativan for anxiety and things like that. I think you have to be very cautious of the respiratory rate issue that we just talked about, because as you see their respiratory rate come down, maybe that's because they're getting better, but maybe it's because you knocked out a little bit of their drive with whatever the pain medication or the anxiety medication that you gave. So I think, as Keith mentioned, I think the dexmedetomidine has been okay in the times that we've used it, but it doesn't always fix the problem that's there, because if the problem is pain, that's probably not going to address it. If the problem is true anxiety, then they may need something more along the lines of a benzodiazepine. So if you're going to administer those, I think it just becomes even more important to assess the respiratory rate and the work of breathing and make sure that they're not related to the medication. If you think that they're coming down because they're improving.
And just another comment for the improving desynchrony. We mentioned respiratory rate. If you're on a device that you're setting the respiratory rate, ensure that it's set really low. Generally, I would set the rate at 10, just because it's a nice even number. And if your patient's breathing less than 10, you probably should be thinking about intubating if they're hypercarbic and breathing that low. But other things to consider is that if you overventilate a patient, you're more likely to have something like ineffective efforts. So ensure that you're not providing too much support. Oftentimes we want to crank up that IPAP to relieve work of breathing, but if you deliver an excessive amount of tidal volume, then you can easily hyperinflate the patient to the point where prior to them having enough sufficient time to exhale this large tidal volume, they try to then take another breath and may have some difficulty triggering the ventilator. This happens a lot in intubated patients, but can happen in NIV if you over-support the patient. So just ensuring that you're providing enough therapy, but not making it so much therapy that they start missing triggers with inspiration, and should be able to recognize that on your waveforms. If you see some obvious signs of the patient taking a breath in, you can look at the patient, look at the waveform. If you don't see a triggered breath, you're likely over supporting that patient, assuming that any sensitivity setting is set appropriately. If it's set appropriately, then it shouldn't be the issue. The issue is likely that you're over supporting the patient and providing too much volume to them.
I think it's important.
That's a really good point. Sorry, Karsten. Yeah, I'll let you go ahead, because I think that's a really good point, Tom. Because when you go start adjusting your IPAP and EPAP, you are affecting obviously ventilation and oxygenation. And if you do over support, then you start to get into possibly PCILI and some other issues that we can see with non-invasive. So, Karsten,
we should also point out that EPAP, just before you go on, Karsten, we should point out that most of the studies in NIV don't use high levels of EPAP. Generally, 8 centimeters of water is usually the highest, because once you go higher than that, you do start having worsening leaks with high EPAP. So sometimes I find clinicians use EPAP as they would PEEP on a ventilator. I wish it was that effective, but generally it ends up with more and more leaks because it is expiratory resistance, and you just end up with more leak around the interface. So the only studies that have utilized higher pressures, there was some CPAP studies previously that used 10 or 12 centimeters of water. But in terms of NIV, the highest settings I've seen are in helmet studies. And again, the helmet's a very different device, and they found that they were able to use higher levels of EPAP without worsening leaks. But in general, EPAPs should be set less than 10 if you want to have an effective seal on your mask. And of course, your delta pressure is where you get your offloading of worker breathing, but too much of that can cause the issues that we've just mentioned. Karsten?
I just want to make sure that we clarify that we're talking about acute respiratory failure. We're not talking about chronic disease processes where patients that have obesity, hypoventilation syndrome, and other neuromuscular diseases that actually need
a rate.
They need modes. They need a mode like AVAPs to give them the backup that they really need. Because I think that this causes a lot of confusion clinically. Constantly having to clarify that acute respiratory failure is different than chronic respiratory failure. I've had that conversation a lot.
Good points. And Chris commented that they use their ICU ventilators for non-invasive and use the pressure support mode, which alleviates the need for setting a rate, which could be useful.
And then Madison just adding a comment that I'm the same way. Over the years, you find these rates being set in the 20s. And again, as Karsten mentioned, you may see rates set at a 20 in someone who's on chronic non-invasive ventilation overnight for sleep issues, for neurological issues, or neuromuscular issues. But in the acute phase, where, as Karsten mentioned, we're talking about patients coming in with acute respiratory failure, and setting that rate higher and higher actually just promotes more dysynchrony with the patient.
Yeah, we're specifically talking about critically ill patients that not the patient that Karsten pointed out. Good point.
All right. I don't know if we got to this one. No, because we added we went through some of the questions. So does neurostatus play a role in whether you initiate one over the other? I mean, I think we've kind of mentioned this throughout our other discussions. Obviously, it comes down to, as Julie mentioned earlier, we need to focus on whether or not it's safe. Can they protect your airway, et cetera? So, if you had a patient who was unconscious and you were not going to intubate them, the application of a mask strapped to the face might seem a bit more risky than putting high flow nasal cannula in their nostrils, where they still have the ability to vomit without it being blown back in their face. It still wouldn't be comfortable to vomit while on high flow nasal cannula, but it would be less comfortable on NIV. I would argue.
Let me just take this to a different direction. I did a talk yesterday at a neurocritical care conference, and my topic was extubating the neuro patient. And an interesting an interesting phenomenon that we may find in neuro patients is that they sort of seem to have a high level of agitation throughout their intubation course, right? And so as a result of that higher level of agitation, they have a lot of movement. And as a result of that, I think that we find upper airway edema and post-extubation stridor a little more common in the neuro patient. And so what we were talking about was, extubating high-risk patients, either patients that have, that have a abnormal amount of secretions, or abnormal characteristics of secretions, maybe not a perfect neurostatus, somebody who's been agitated chronically for a few days, etc. What choice would you make to extubate that patient? And my question would be to the panel: if you suspect a patient is at higher risk of post-extubation stridor, is there utility in extubating that patient to heated high flow nasal cannula? What are your thoughts on that?
I'm not sure I'm following. If you're concerning about post-extubation stridor, wouldn't you just treat with steroids? And then I'm not sure if I understand the question.
Yeah, you certainly could. So that's probably something we would probably empirically, like if somebody had been extubated once before and had problems and got reintubated, or if they have a C-spine lesion, or if they have a C-spine fracture, if they've been intubated for several weeks or a couple of weeks, et cetera, then we would empirically treat them with steroids. Yeah, exactly.
Yeah.
Prior to. My question more is just the average patient that that might not fit those occult, those occult issues that we just talked about. Maybe just a standard issue patient that's intubated for 3 or 4 days, but has been agitated and maybe had more movement in their upper airway because of that. And you decided that you were going to go ahead and just empirically extubate them to some sort of some level of non-invasive support.
Yeah, I don't think sorry, I was just gonna say I don't think there's specific evidence or guidelines like that would like strongly suggest one over the other. We do have evidence that extubating patients that are low or high risk you can reduce reintubation rates with high flow and with NIV for high risk patients. I think it would come down to if this is a patient who was just essentially neurological issues, you're worried about airways, and you want to reduce some post-extubation work of breathing to facilitate with any possible airway resistance they may have. I think high flow nasal cannula would be sufficient. However, if the patient had some also or additionally underlying hypercarbia, or even a slightly lower pH, then you may want to choose NIV. But I think for comfort reasons and just for the ability of reducing some work of breathing as well as providing some heated humidity, I think NIV personally would be probably a first choice for me, but that's not based on, large, strong recommendations based on high quality evidence. That would just be a preference, knowing that they would be considered a probably moderate to high risk of extubation failure. If the only issue you're worried about is the airway, then essentially, you can reduce work of breathing with either therapy. But if you do have high CO2, again, I probably would lean towards something like NIV if the patient tolerates it. But if they've been very agitated on the ventilator, I wouldn't be surprised if they were extremely agitated on NIV as well. So I think my first choice would be high flow. I don't know if others would agree or disagree. I see Julie nodding her head, so I think Julie agrees.
Yeah, I do agree with you on that. I agree with what you all said, but I think the thing is, as we go back to individualizing the care again, I was gonna agree with Tom on like if they were agitated on the vent, putting a non-invasive mask on them, unless they had a high CO2 or were acidotic with that, I think I would probably choose the high flow cannula because I think the comfort in and of itself is going to be easier to tolerate, less likely to have to fight the battle of keeping the mask on constantly. things like that. So I personally would probably extubate that patient to high flow. The heat and humidification obviously is going to help with secretion management. I agree with everyone else. I think steroids would be appropriate for that patient, but I don't think that it's a bad thing to have the continued humidification for those patients. I don't know that there's any studies that say it actually reduces the swelling per se. I think steroids would do a better job with that. But I personally agree with what Tom says. I would extubate to high flow unless there was an acidemia issue that I was concerned with, just for comfort, and probably less likely to have to give a lot of meds to keep the patient in the bed, which is something we're always looking at decreasing as well. So they already have neuro issues. We don't need to add any additional delirium or any crazy stuff like that to that problem. So.
Yeah. And I think keeping in mind that, well, first of all, there are many patients that can't get steroids for one reason or another. A patient that has an infectious encephalitis, and that's why they were intubated for, people look at you like you've lost your mind if you want to give those people steroids. But also keeping in mind that there's a real high failure rate when you wait and institute non-invasive support after they start to fail, right? So do you have a different threshold for just going ahead and extubating? So I do personally in my practice. If I have any doubt whether or not somebody looks amazing before I extubate them, that I've been extubating them right to high flow. We should probably, do that.
Yeah, I mean, I think we've actually answered many of these questions. The second last one, what's your threshold regarding hypercarbia or acidemia, whether or not to initiate high flow over NIV? And I think it was either John or Eric that brought up that we probably should be specifically talking about pH rather than just CO2, because they may have a chronically high CO2. So I think respiratory acidosis in general, and probably the more severe, the more likely you're going to lean towards NIV. Having said that, in post-extubation patients, in the most recent paper by Thiel, I believe, out of France, Thille, they found that, so they extubated patients to either NIV with high flow during breaks or just high flow. And there was a benefit towards NIV, but it was, when they broke it down, it was specific to the patients with a CO2 greater than 45. So, it was greater than 45. And it really wasn't pH related. It was just these patients had chronically high CO2. So again, maybe they weren't acidotic, but because they have high CO2s, perhaps they are in that category of patients that may have some chronic issues that may just have benefited from the additional support with NIV. So again, I would say in the acute phase, which post-extubation, you should be in the getting better phase if you're extubating the patient. But in the pre-intubation phase, the point of trying to avoid intubation, I think if your patient has respiratory acidosis, probably choosing NIV over high flow would get the biggest bang for your buck quickly. Any other comments on that one? I think we've answered the last one.
I'm going to add one more thing. There was a second study done by Thiel shortly after that first one, where they broke down and they actually looked at obesity in these patients. And what they found was that the patients that were underweight or normal weight, when they had other high risk features, they actually did worse extubating them to high flow than they did non-invasive. But the patients that were extreme obesity, or kind of just slightly overweight, did better extubating to high flow than non-invasive. So I think, again, we can't bucket everybody into the same criteria. You really have to continue to individualize it. I found that paper very interesting. I think intuitively for me, I was like, oh, the patient that's underweight or just normal weight would probably do fine on high flow, even if they had other characteristics that would make them at risk. And that's not what they showed. So it was a very interesting secondary analysis of their initial paper that you referenced, Tom, just kind of taking a look at that. So just reminded me that we really have to individualize care a little bit more for every patient and not just lump everybody into the same bucket.
So patients with a larger BMI and body habitus did better with high flow as opposed to non-invasive.
Yeah, in that particular study, they did better. They pointed out a lot of different reasons, but a lot of it they felt were, just the overall compliance for the patient, compared to non-invasive. A lot of those patients probably should have been utilizing some sort of non-invasive support device at home, because clearly they would have met some of that criteria, but they weren't compliant with it, or they weren't ever diagnosed, and so they weren't compliant during this, when they were extubating them. They were having to use a lot more medications to keep them compliant with the therapy. So there's kind of, I don't know, it's kind of an interesting secondary analysis to that initial paper that they came out with. I think it was about year after, or maybe it was 6 months after they published the first one. I'll see if I can find it and put it in the reference section or in the chat here really quick.
I'm going to post one here. Just let me know. I'm just kind of looking through it right now, but you can let me know if this is the one. It is a post hoc analysis, but I'm looking
Yes,
for
it is a post hoc analysis one. Yeah, I'm trying to look through all my papers really quick and see if I can find it really fast too.
Were there any other questions in the comments or anything, Tom?
Just Madison letting everybody know for registrations how people can get notified.
Yeah, so anybody who's listening to this or might listen to it later when we post the recording, go ahead and go to our website and register, and you'll get notifications about future panel discussions. Our next panel discussion is going to be how to read a research article. And so, so that's what our next discussion will be on. We're over an hour now, and so I'll go ahead and just say thank you to the panelists again. We appreciate you volunteering your time. Appreciate you volunteering your expertise, and we appreciate the folks who logged on to participate in this discussion. So with that, I think that I'll say good day, and just appreciate all of you so much.
Keep on keeping on, guys.
Yep, same.
See ya.
Here we go.
All right. Thank you.